Hello, my name is Rich, one of the co-founders of Bite Medicine. Today we'll be doing part one of a series in oncology. For those who haven't used Bite Medicine before or are fairly new to it, this is what we are. We have live webinars that we try and do at least on a weekly basis. We also have a question bank that we're constantly trying to improve upon, and its current format is a multi-step SBA format, so a single case vignette with sort of sequential questions, and that's how we're going to run today's session as well. There's also an online textbook that comes with it, which we've tried to make as thorough, but as sort of condensed as possible. In terms of the structure of today, so over the next two sessions, we're going to be covering an overview of cancer and then these four oncological emergencies. I'm going to omit which two we're covering today, because I think that'll be a little bit of a spoiler for our cases and our questions. But for those who haven't used or been to these webinars before, it seems to be a fantastic turnout as well, so welcome all. But if you use the Menti code, if you go on your phone or your laptop and you type in menti.com, it'll ask you for a code. The code is 96405795. That'll allow you to play along with all the questions that we have today in store for you, and there's quite a few. And I'm just going to type the code in the chat as well for those of you who can read that as well. So, as I say, we'll keep it to under 60 minutes. And for those who have access to our app and you use the website, then you can watch this later on as a recording as well. So, I did just want to start the session. I think it's fair to say that cancer is a very sensitive topic, as is oncology. I'm sure most of the people that are attending this, as well as myself, have personal attachments to individuals who have suffered with cancer or know people who have suffered with cancer. So I did just want to say, upright that I've tried to handle material as sensitively as possible. But if you are offended or you do find that this is upsetting, you can always reach out to myself or someone within your own sort of community after the event. So, an introduction. When it comes to learning oncology at med school or as a PA, I think my advice, I've kind of listed what I would recommend doing. So, know your common cancers. So, for each sort of specialty that you're learning, be it GI, respiratory, neurology, know the malignancies that you find within each of these kind of organ systems. So, the GI malignancies, the lung cancers, the brain tumors, know about them. How do they present? And learn about them. My advice would be learn about them within those specialties as you're learning them, rather than as a separate oncology, though you can do it that way if you wish. Don't just know how they present, but how would you go about investigating and diagnosing them? What imaging tests would you use? What blood tests, what tumor markers, biopsies, that kind of thing around each cancer will serve you really well, not only in the exams, but in sort of wider clinical practice as well. And then a brief kind of understanding of how the management works for these common cancers. We'll touch upon it today, but in general rules, it tends to be surgery, radiotherapy, chemotherapy as our kind of big three. And then, as modern medicine sort of progresses, we're now getting these wonder drugs, these molecularly targeted therapies, immunotherapies, and all sorts of refined treatments that are ever improving prognosis. Then know about your oncological emergencies, which we're going to be covering. Paraneoplastic syndromes, I'm hoping to do a session on this in the near future. These are essentially often endocrine or other presentations that a patient with cancer might present with. So, for example, they might come in with hypercalcemia, and that's due to a particular endocrine sort of issue, or they might come in with super high HB to a dangerous level, and that's due to erythropoietin. And these are all kind of called the paraneoplastic syndromes. So it's worth learning those. And then a brief bit about genetics. It's classic bait for an SBA exam is to be asked, they've got this gene mutation, what predisposition syndrome do they have, or whatever. And you could argue it's not super useful for clinical practice. Some would argue otherwise, but it is pretty, essential for your exams. And then pediatric oncology, a bit like with the other cancers, I would learn that when you're doing your pediatric specialist block. So I thought it would be quite fun just to kick off with a few rapid fire questions. So these are a mixture of statistics from the CR UK website, as well as some ones that are quite commonly seen in exams. So as I said before, for those who've only just joined, if you go to menti.com and use the code 96405795, it's in the chat, and we'll start with our first question now. So I'll head over to Menti myself. So, which of the following is the most common cancer in the UK? And we've got bowel, breast, lung, melanoma, and prostate. Just let you guys continue to join the menti.com. So, as I say, 96, 40, 57, 95. So, rapid fire. Let's see what people are saying. So, okay. You've sort of torn between breast and lung there. Fantastic to the majority. Well done. Yeah, breast is the most common cancer in the UK. I think it's somewhere between 15 and 18% of all cancers, are breast cancers. So well done. So next question. As I said, there's a rapid fire. We won't spend ages discussing the answers like we will later on. So which of the following is the most common cause of cancer-related death in the UK? So we've got the same 5 cancers here. Okay, right, clear majority thinking it's lung. And again, absolutely right. Yeah, well done. So although breast is the most common cancer, the most common cancer-related death is with lung cancer. It's got quite a poor mortality given its prevalence. There are, of course, certain cancers that have an even poorer prognosis, but tend to be a lot rarer. So, next question. I think there's 5 of these in total. So, which of the following is frequently overexpressed in cancer cells? So this sort of draws upon your preclinical knowledge for many of you. So we've got APC, MYC, P10, P53, and PRB. Okay, let's see where the votes are going. Okay. So majority of you going for P53. So interestingly enough, it's actually MYC. So I think what this question is looking at here is the difference between tumor suppressor genes and oncogenes. So MYC is an oncogene, so it drives cell growth. And therefore, if it's overexpressed, you've got too much driver and therefore too much cancerous growth. P53 is a tumor suppressor. So, it can be overexpressed as a mutant form, but overall it tends to be kind of just, the normal P53 protein is not overexpressed, because if it were, you wouldn't be getting cancer driver. And P10 and PRB are 2 other quite prominent tumor suppressor genes within cells, as is APC, though APC is more about a particular predisposition syndrome. So yeah, so it's MYC. So well done for those who got that. And we've got a bit of a wordy one here. So which of the following predisposition syndromes arises due to mutation in MLH1 in the germ cell lineage? And we've got Cowden syndrome, familial adenomatous polyposis, hereditary non-polyposis colorectal cancer, Lee-Fraumeni syndrome, and von Hippel-Lindau syndrome. Slightly slower responses with this one. Maybe it's a bit more tricky. Okay. Fine. So majority are thinking HNPCC. You'd be right on the money. Well done. Yes. So working from left to right. So Cowden syndrome, predisposition syndrome, if you have the P10 mutation, that's PTEN, which is the sort of the antagonizing driver in the PI3 kinase pathway. Familial adenomatous polyposis. So if you have a mutation in your your APC gene, then what you can get is widespread polyps throughout the colon, which is predisposes you to colorectal cancer. The middle one, which is the one most of you got correct, this is Lynch syndrome, which you may have heard it being called Lynch syndrome or HNPCC. So it's mutations in MLH1 or MSH2 that can drive this risk of colorectal cancer in this population. Li-Fraumeni syndrome is a P53 mutation, and von Hippel-Lindau syndrome, you get mutations in the VHL gene. So yeah, well done to those who got that one right. Fantastic stuff. And finally then, to finish off on the quick fire, we've got a question about tumor markers, a little bit of a flavor of what kind of oncology questions you can get. So which of the following tumor markers is likely to be raised in non-seminomatous testicular cancer? These are things like yolk sac and teratoma. Okay. So majority are thinking AFP, and some of you are thinking HCG. So you're all correct in having, or most of you are correct in having identified the two tumor markers that tend to be linked to testicular cancers. The correct answer is the majority. Well done, it's AFP. So non-seminomatous components will produce AFP. A seminoma will not. For HCG, so the HCG comes when your testicular cancer differentiates into syncytial trophoblasts, essentially, which can produce HCG, a bit like in the placenta where we produce HCG. So both seminomas and non-seminomatous testicular cancers both have the potential to undergo that differentiation into syncytial trophoblasts and therefore produce HCG. But the one that's more likely to be raised in the non-seminomatous type is AFP. And you may have heard stories of men urinating on pregnancy tests for whatever reason and them coming up positive, and there's these kind of anecdotal stories about that being a screening for testicular cancer. It's not used as screening, but there have been stories where it's been picked up that way. So yeah, well done to those of you who got that right. We're going to head back to the main PowerPoint now. So these are the questions which you'll have access to in the slides that you can download. So a little bit of a background on cancer before we launch into our emergencies. So it's an abnormally regulated cell growth, either in solid tumors or in blood cancers. So don't forget your leukemias, lymphomas. For something to be cancerous, it must have the ability to spread. It doesn't have to have metastasized, which is what we call the spread, but it has to have the ability to do so. And it can spread through either direct spread, so it can sort of grow outside, push against adjacent structures. It can make its way into the lymphatics and spread out that way, which is why you often hear about cancers being found in the nearby lymph nodes. It spreads through that manner. Or it can pass through hematogenous spread, which is where it gets into the bloodstream, and that's how it gets to more distant structures. And there's a little image here that shows that kind of summary. And that, looking at these here, these circulating tumor cells or CTCs, there are research labs around the world that are working on just targeting CTCs or just targeting, the pre-metastatic tumor. That it's a fascinating field. So how does this abnormal cell growth occur? My favorite definition is actually from SAW 3, where they say it's when the rate of growth outweighs the rate of apoptosis, which I think is a really nice way to think about it. But essentially what is happening, you are getting hits or DNA damage or mutations within your genetic material within a single cell, and that damage is not recognized and repaired, because we do have sort of fantastic mechanisms, 5, 6, 7 different sort of classes of repair mechanisms that can, are there to catch this. And when they don't catch it and the mutation gets propagated into the next cell lineage, that's when the problems start occurring. So how does it occur? Well, you get a single mutation. So you can get hits all the time, and we all do. And sometimes these hits get fixed. Sometimes these hits land in really uneventful places within our genetic material. Every now and again, they'll land in a critical base. One of those bases will get changed, and it could be in a tumor suppressor gene, it could be in an oncogene, or it could be in a regulatory genetic sort of bit of material that is acting upon a critical TSG or oncogene. Ultimately, though, this can lead to a predisposition to further mutations or to further growth. Subsequently, you then start to lose your DNA repair mechanisms, makes your cell even more susceptible to further damage, and then you get this exponential growth and what we call a change in phenotype. For those who are really interested, you can go away and read about the hallmarks of cancer, which is by Hanahan and Weinberg. It's a series of research papers. When we refer to change in phenotype, you might see these terms: hyperplasia, metaplasia, dysplasia, neoplasia. Essentially, hyperplasia is just too much growth, but the cells are exactly the same as they were, with the original cell. Metaplasia is when they've gone from a particular cell type to another. So an example could be when something goes from a sort of columnar cell type to a squamous cell type. That process is called metaplasia. Dysplasia is when the cells no longer resemble how they formerly looked and potentially don't act that way as well. And with dysplasia, we often think of it as a pre-malignant state, but there is possibility that it can regress, whereas neoplasia is your full-blown sort of cancerous cells. So a quick bit about causes, why we get these hits. So drug causes, so HRT can cause these hits. Infections, so viruses, chronic infection with H. pylori, so this kind of chronic inflammation creates reactive oxygen species which can damage your DNA. And then environmental factors, I think we all know these: smoking, obesity, poor diet, alcohol, radiation. They're all things that can incur damage to our DNA. And then a little bit about treatment. So I think we all still know that surgery is probably the best curative option, essentially taking out the tumor, leaving a good kind of resection margin so that you can take in as much as you can out with or without adjacent lymph nodes. It remains the best option. Chemotherapy, so these are the toxic drugs that you can give to kill rapidly dividing cells. They often target the cancer cells, but by proxy will end up attacking hair follicles, blood cells, which is why you get some of the nasty side effects with it. And you can give these either as adjuvant therapy, so kind of after surgery, neoadjuvant therapy, so before surgery, or palliative. So you're not looking for curative intent, but you potentially could improve quality of life or some kind of time benefit. And then radiotherapy, essentially blasting the tumor with ionizing radiation at high frequency, or high grays, I should say, to induce so many mutations in the cells that the cell can't survive and it dies. The risk of that is that radiation could damage other cells, but there is, I think, a low kind of incidence or as an adverse effect that you can get a secondary cancer from it. And I briefly alluded to this earlier, this molecularly targeted therapy. So knowing the exact protein pathways of all these different cells allows us to target them with really amazing tablets, and so some of them are IV, some of them are tablets, that can stop these pathways and revolutionize outcome. And then also this new, or I say new, it's less new now, immunotherapy. So essentially getting your host immune system to fight off cancer cells. And then with regards to mortality, before we move on, so things that can kill you from cancer is so general kind of weakness and wasting of the body, multi-organ failure, if it invades into a particular blood vessel that causes hemorrhage and subsequent complications from that, compression of lesions, e.g. the brain, the spinal cord, paraneoplastic symptoms, and then your oncological emergencies. So that's kind of a whistle-stop tour through cancer for those who may not have covered it for a while, if you're new to your clinical and you haven't done preclinical in a little while. So now we're going to focus more on the clinical side of things with oncological emergencies. So our first case of the day, we have got a 33-year-old male, and he is diagnosed with non-Hodgkin's lymphoma, so a malignancy of your lymphoid tissue, after a 3-month history of having night sweats and weight loss, the so-called B symptoms. He's commenced on a chemoradiotherapy regimen, including R-CHOP. So R-CHOP is a number of different chemotherapies together. I think you've got rituximab there, which binds CD20, cyclophosphamide, H and O, I think H is hydroxydornarubicin, O oncovin, and P is prednisolone. So he's brought to ED with a 3-day history of minimal urine output. This is after he's had his chemotherapy. He feels extremely nauseous but denies vomiting or diarrhea. And his bloods are thus: calcium 2.1, also slightly lower, phosphate 1.05, also slightly higher, and uric acid of 500. That's pretty high. So the question I pose to you guys, and we'll head back to Menti, is thus: which of the following is most likely to be responsible for the patient's presentation? Now, options here are dehydration, lymphoma infiltration of the kidneys, nephrocalcinosis, steroid nephropathy, uric acid nephropathy. So we've got 33-year-old male with non-Hodgkin's lymphoma, and he was started on chemotherapy and then some days later has come into hospital with a 3-day history of poor urine output, nausea and vomit, nausea but no vomiting. And he's got a high uric acid, a slightly low calcium, and a slightly high phosphate. Let's see what you guys are thinking. So majority are looking at uric acid nephropathy. Okay. You'd be absolutely correct. Yeah, well done. So uric acid nephropathy is the correct answer. So you might not have heard this, what this is before. So let's have a quick talk through it. So working top down, although a patient has oliguria and dehydration is a cause of that, we haven't heard of any reason why this patient has, reduced his oil intake or has excessive fluid loss. It's, it's probably not the main reason. Lymphoma infiltration of the kidneys would not account for his high urea in this sense alone. Nephrocalcinosis, so this is where you get calcium in your blood binding with too much phosphate to form calcium phosphate crystals. These then plug in the kidney and can damage it. Now his calcium was only slightly low and his phosphate was only slightly high, so potentially wasn't that, but could have been a cause. Steroid nephropathy is not a thing that we see commonly, which leaves us with uric acid nephropathy. So this patient has come in with a blood cell malignancy, a lymphoma. He has been given chemotherapy. The likely answer here is that he has undergone something called tumor lysis syndrome. Essentially, his cells have burst open and leached all of their intracellular contents into the blood, which would explain his high uric acid level and also his high phosphate level. And what can happen is this uric acid level can precipitate into urate crystals, block the renal tubules, and you get an obstruction. So let's have a little bit of a chat about tumor lysis syndrome in a bit more detail. So here we've got a balloon representation of tumor lysis syndrome. So it's a metabolic complication, occurs with treatment of cancer. As I said, your intracellular components pour out into the systemic circulation, which is why it tends to be in hematological malignancies where they already kind of have access to the bloodstream because they're in there. So things we see. So we're all aware that a lot of our potassium is stored intracellularly. If those cells burst or lyse, that gets released out and we can become hyperkalemic. Likewise, we have high phosphate levels. If you think that the sugar phosphate backbone of DNA has got phosphate in it, that's going to cause hyperphosphatemia, which on its own is not terrible, but what hyperphosphatemia can do is bind to calcium in sort of free ionized calcium in the blood and can precipitate it. And that's bad because then it will cause hypocalcemia. And the final one is uric acid. So what happens is our purines, which are a particular type of base, or nucleotide, I should say, they get metabolized into uric acid, and that causes hyperuricemia, which can be dangerous because it can cause uric acid. So looking at the clinical features of each of these metabolic concerns, so with hyperkalemia, tend to get muscle weakness and cramps, paresthesia, so tingling, and palpitations, which is really, really dangerous for the heart, as I'm sure you're all aware, particularly can predispose to tachyarrhythmias. Hyperphosphatemia, as I've already said, tends not to have symptoms itself, but can precipitate the calcium. And what calcium phosphate precipitates can do is deposit in the skin, causing itchiness, and also clog our renal tubules, causing that nephrocalcinosis. So that's for hyperkalemia and hyperphosphatemia. There are our direct changes due to cell lysis. And then the indirect ones, so hypocalcemia occurs because of the phosphate. Here we get tingling, muscle cramps. If it's really low, you can get seizures. And you get these two signs. So you get Trousseau's sign of latent tetany. So classically, if you sort of put a blood pressure cuff or a tourniquet on the arm, you can get spasming of the distal muscles. And Chvostek's sign is where if you tap the sort of cheek muscles or the kind of the nerve that enters in the infraorbital region, you can kind of set off a sort of twitching of the muscles in the face. And those are quite specific for hypocalcemia. And they're good ones to know about for your exams because it can sometimes be the distinguishing feature that will get you to the right answer. And then for hyperuricemia, we've already talked quite a lot about uric acid nephropathy, and then also you can get gout from it. So not very pleasant. That is tumor lysis syndrome. And how do we sort of officially diagnose it? Well, they recommend that for biochemical diagnosis, you have 2 or more of the 4 metabolic abnormalities or oliguria despite adequate hydration. And I wouldn't say you need to remember these numbers here. I think if they were going to ask you at finals level, they would make the numbers pretty high, so it's fairly obvious what's going on. And there's also then now a clinical diagnosis where there have to be some laboratory features together with some more severe features like arrhythmia, seizure, or sudden death. So for this is for more interest. I don't think you need to sort of learn this or rote learn it. I think you just need to be aware of which electrolytes are going up and which metabolites and electrolytes are going down. And I think it will be fairly obvious in an exam setting. And from a clinical point of view, if you're clerking a patient in who's recently had chemotherapy, sometimes you might need to think about adding on to your blood tests, uric acid, phosphate, maybe a calcium. So just something to think about when you get to the hospital setting. So back to another question. So, which of the following factors may have contributed to this presentation? The options are age less than 40, caffeine use, loop diuretics, salbutamol use, or smoking. So, going for loop diuretics. So interestingly enough, I would agree if this is purely for the oliguria, if the patients become so dehydrated from excess diuresis that they've eventually become oliguric. But actually, you would more expect if someone was on loop diuretics to be diuresing, not oliguric. Interestingly, it's caffeine use. So risk factors for a uric acid nephropathy. Advancing age, as you get older, you're less able to handle the tumor lysis syndrome. Caffeine use can drive raised uric acid. Thiazide diuretics can contribute to it, but not loop diuretics. Salbutamol use can't, and it's alcohol, not smoking, that tends to have an impact on uric acid nephropathy. So a bit of a tricky one there. So in terms of risk factors for general tumor lysis syndrome, so who's at more risk of getting it? If you've got a large tumor and then you go and give chemo or radiotherapy, you're going to get more cell lysis. I think that's very intuitive. Likewise, if you've got a cell that has rapid cell turnover, that's also the case. If your kidneys are already not fantastic, you're going to be less well equipped to be able to deal with any metabolic abnormalities that occur. If the tumor is already involving the kidney as well, that will impair the kidney. Advancing age, cell cycle specific cytotoxics, and then these drugs that I briefly mentioned that increase alcohol levels. There's some here. So I think that was a pretty tough one, to be honest. So next part of this patient's history. So he complains of terrible muscle cramps in his thighs. His heart rate is 110, blood pressure 115/90, saturating well, no temperature. And his U's come back, and he clearly has got some sort of problem going on. His creatinine is quite high, a little bit dehydrated there with his sodium, and his potassium is 6.6. The question I pose to you is, given the blood results, which of the following ECG features is most likely to be present? So back to Menti for those who are playing along. So given the blood results, which of the following ECG features is most likely to be present? Biphasic P waves, PR depression, short QT interval, sine waves, T wave inversion. Let's see where these votes go. Okay, very interesting. Majority wins. Well done. Yes, fantastic stuff. So biphasic P waves, no. If we can talk through all the different features. So as hyperkalemia becomes more severe, you tend to get flattening of the P wave. PR depression tends to be a feature of pericarditis, not hyperkalemia. Short QT is a feature. The sine wave that we see is actually when your QRS starts to broaden and then merges with your tented T wave. So you start to get a literal sine wave. It's very late stage. If you see that, panic, alert a senior. And you don't get T wave inversion, you tend to get tented T waves. The way I used to think about kind of remembering the hyperkalemia was tented T waves is the first one. I could remember that. And then I would imagine two people standing on either side pulling on the ECG strip. And if they pulled it, what would happen? So your QRS complex would broaden out, your P wave would flatten, and then by pulling that out, your QT distance potentially gets shorter. And that, for me, that works quite well. Fine. So given that the ECG shows tented T waves, what is the most appropriate next step? So this is, I don't think I sat a single SBA exam in my clinical years where this question did not come up in some format. I have had maybe 3 cases where I've had to administer this particular answer since being a doctor. So yeah, make sure you know it. So the options are calcium gluconate, calcium resonium, insulin dextrose, salbutamol nebulizer, sodium bicarbonate. What is the most appropriate next step? So majority are going for calcium gluconate, and then some people have said insulin dextrose. So majority is correct. For the 13% that said insulin dex, it's just wording of the question here. You're absolutely right to give insulin dextrose, but the most important thing when you've got a hyperkalemic patient with ECG changes is to give the membrane stabilizer, the cardiac membrane stabilizer, which is calcium gluconate. Almost immediately after, you'll give insulin dextrose, but you know, if you've got, you know, a short-staffed nursing team and you say you need to prioritize giving this one now, it's the calcium gluconate. So yeah, well done to the majority there. So let's head back. For those who, yeah, I mean, none of you got caught out, but they'll often throw calcium resonium in as a kind of red herring. This would be a much slower acting way to bring down your potassium. Essentially, it's oral or rectal. It binds the potassium in your gut and helps you excrete it so you don't absorb it. So his potassium is stabilized with calcium gluconate, IV insulin dextrose, and nebulized salbutamol. He's monitored in hospital and given adequate IV hydration. His renal function recovers well and electrolytes normalize. He is discharged. A CT scan shows that his tumor is shrinking, it's less than 5 centimeters, and his LDH is normalizing. He's scheduled for a repeat dose of his chemotherapy. Which is the most appropriate medication to commence prior to chemotherapy? We've got the last question for our first oncological emergency. Oh, yeah, there we go. So what's the most appropriate medication to commence prior to chemotherapy? We've got allopurinol, calcium carbonate and vitamin D3, calcium resonium, colchicine, and rasburicase. LDH is lactate dehydrogenase. That's just a question. It can increase with these malignancies due to kind of rapid cell turnover. So the fact that it's coming down is a good sign. So let's see what people are thinking. Fantastic. Yeah, bang on. Well done. So the majority have gone for allopurinol. You're absolutely correct to say this. Well done. So let's have a little look at why that is correct and why the second most answered option for rasburicase is not. It's all about recognizing high risk versus low risk TLS patients. So who's going to suffer if they get TLS? So what we tend to do is for the low intermediate ones, and we'll look at who they are, you tend to start allopurinol 1 to 2 days prior to chemotherapy, as well as a bit of IVI to basically act as a prophylaxis against the uric acid rise. Calcium carbonate and vitamin D3, the patient didn't have, his electrolytes were normalized, so you don't need to give that. Likewise for calcium resonium. Colchicine is an acute management option for gout, so you wouldn't use it as prophylaxis. And rasburicase is an option, but it tends to be reserved for high-risk patients. So let's have a look at these 2 drugs in a bit more detail. So allopurinol inhibits xanthine oxidase, which normally converts purine to uric acid. So by blocking that, you don't get that uric acid conversion. You tend to give it in sort of tablet form, 1 to 3 divided doses, 7 days. And as I say, usually commence 1 to 2 days prior to treatment. As for rasburicase, this is, I think it's an enzyme essentially that converts your uric acid into metabolites. And it's given to your high-risk patients, so patients with Burkitt's or lymphoblastic lymphoma, high-grade lymphoma of any type, so tumor more than 10 centimeters, bulky disease, raised LDH. Of course, in our case, these were all, you know, it was coming down. If they have the leukemias with a white cell of more than 100, or a chronic leukemia with a white cell more than 100. So slightly niche question to finish on, but the point I'm making is if they're going to test you at tumor lysis syndrome and they want to know what your prophylactic drug of choice would be, the answer tends to be allopurinol, unless they have a really significant lymphoma burden or leukemic burden. And then you give rasburicase. So that's tumor lysis syndrome. Summary being raised potassium, raised phosphate. Your phosphate binds to your calcium, causing low calcium, and you get raised uric acid. Those are the 4 to remember. So moving on to case number 2. So we've got a 76-year-old man who presents to his GP with a 6-month history of sleep disturbance. He's finding that he's going to the toilet to pass urine multiple times in the night, and he reports that despite frequent urge, he will have trouble passing urine and has terminal dribbling. On examination, he has a large body habitus. A digital rectal examination finds the man to have an asymmetrical nodular prostate with loss of the medial sulcus. So, our question: given the likely diagnosis, which is the most appropriate initial diagnostic investigation? There's only 3 questions for this case, so it's slightly shorter for those who are wanting to get on with their Monday evening. So our options are CA19-9, multi-parametric or MP MRI, MP MRI influenced prostate biopsy, prostate-specific antigen, or transrectal ultrasound guided needle biopsy. So, very interesting. So I learned a lot by preparing this particular part of the webinar, and I will signpost you to the NICE guidelines for prostate cancer. Actually. So the answer is multi-parametric MRI, interestingly enough. So nowadays, if you have a suspicion for a localized prostate cancer, the recommendation is that you do an MP MRI. So it's a multiple different kind of angles and images to produce a really high quality image of the prostate. And then it is scored using Likert scaling. So you know that 5-step, highly likely, highly unlikely, and everything in between. And then based on that probability of malignancy, that will be used to determine whether or not a biopsy is needed. And if it's a biopsy is needed, then it's an MP MRI influenced prostate biopsy that can be done either transrectally or otherwise. So yeah, correct answer there was MP MRI, which I think is very interesting. So before we go on to the emergency issue of this particular case, we can just have a little look through prostate cancer as a one-page summary, which you can use for your revision. So features that tend to arise are lower urinary tract symptoms, so nocturia, urinating in the night, frequency, urgency, terminal dribbling. You might get hesitancy, so the need to go, but then you can't quite go. More rarely, you get the features that we more associate with bladder cancer or urinary tract infections, so hematuria and dysuria. There may be constitutional symptoms like weight loss, and something that you can almost parrot learn and recognize in your exam for kind of almost pathognomic would be asymmetrical hard nodular prostate with loss of the median sulcus. It's very much indicative of prostate cancer, as opposed to a kind of more diffuse swelling that is symmetrical. That tends to be BPH, and boggy swelling tends to be prostatitis. Also, that would be painful. So you learn your kind of ways to differentiate those descriptions. as I say, in terms of investigations, you start with a multi-parametric MRI, and we Likert scale it. If it's 3 or more, you'd probably go for a biopsy. 1 to 2, you might offer one. For those who take prostate-specific antigen, which I think was the majority of you, this might be used to help a patient decide if they need an MRI or biopsy. But in terms of the current prostate cancer guidance, it's not what they're recommending. I think in clinical practice, it's still used quite a lot. And I think it's also used for prognostic reasons. But there are a lot of things that can cause false positives with PSA, even things like, vigorous exercise, a recent prostate exam. There's a number of different things that can skew those results. And then in terms of management for low to intermediate risk localized prostate cancers, you offer 3 things. You can offer active surveillance, so just keeping an eye on it with a strict sort of callback system, checking on symptoms, offering again, radical prostatectomy, or radiotherapy, which is either done through external beams, or brachytherapy, where they actually apply radiotherapy next to the prostate, so within the rectum. And I believe it kind of emits like a localized radiation when hit with certain beams, which is quite interesting. That's your 1-page summary of prostate cancer. So now we've got a bit of a flavor. So this patient has a multi-parametric MRI, and it strongly suggests prostate cancer. He undergoes a biopsy, and he is histology graded as Gleason score 7. So the way that the Gleason scoring works is they look at your cell types within the biopsy. The most prevalent histological cell type gets a grade from 1 to 5, with 5 being, highly cancerous. The second most prevalent cell type then also gets scored in the same system. And so the worst you could get is a 5, and a 5 would be a 10. In this case, his most prevalent cell type is a 3, and the second most prevalent cell type is a 4, giving him a fair intermediate likelihood of prostate cancer. He elects not to have any treatment and to have active surveillance. So 6 months later, he's brought into the emergency department with urinary retention. He's been unable to pass urine for 36 hours, and on further questioning, he actually admits that he's had a 1-month history of back pain. On examination, he has 4 out of 5 power in the right ankle, but 5 out of 5 power elsewhere. He has absent right-sided ankle and knee reflexes, so hyporeflexia. Digital rectal examination is unremarkable, but there is saddle anesthesia. So, heading to Menti for our penultimate question of the day. So, which is the most likely explanation for the patient's presentation? Cauda equina syndrome, conus medullaris syndrome, spinal cord metastases, so metastases within the actual spinal cord, obstructive uropathy secondary to primary tumor, paraneoplastic multiple sclerosis. See where you guys are voting. Okay. Very interesting. So, as tends to be the case, majority wins, so well done. So let's have a little look at what's going on here. I think there's some important kind of terminology and definitions to learn here that are very useful. So, unmanaged prostate cancer with back pain, definitely worry about metastasis somewhere within your vertebral column, potentially impacting upon the nervous tissue within it. Add in urinary retention, you become very worried about metastasis within the spine. However, for cauda equina, which is the bundle of nerves that have left the spinal cord, so they are lower motor neurons, if they're the ones that are involved, it is known as cauda equina syndrome, and it tends to present with a unilateral lower motor neuron sign. So this patient had right-sided reduced power, as well as right-sided hyporeflexia. Conus medullaris syndrome, and we're going to look at the anatomy of the spinal cord in a second. Conus medullaris is right at the bottom, the tip between the spinal cord and the cauda equina, and it tends to produce a mixed upper motor neuron, lower motor neuron presentation. And don't worry about jotting all this down because we've got it on the next slide. And it tends to be bilateral. So that makes that one less likely. And the same goes for spinal cord, like true cord metastases, in that it would more likely be an upper motor neuron presentation. So cauda equina is the one that is most likely here, and obstructive uropathy would not explain the whole presentation. And paraneoplastic MS, it's not entirely sure it's a true thing. There's some hypothesis out there that some MS arises due to cancer as a paraneoplastic process, but poor evidence base. So looking at this as a summary, we call this metastatic spinal cord compression. This is the overall term for when cancer grows in proximity to the spinal cord or the adjacent nerves. The common offenders are lung, prostate, and breast. Now, looking at this anatomy on the right here, so you've got your spinal cord at the top, and then coming down that little tip there, you've got your conus medullaris, and then coming off, we've got our horse's tail, or cauda equina. So all of them will present potentially with these features. So new back pain, really, really important one to ask about. It might have a radicular component, so a particular nerve involvement or particular nerve level. So you might have like an L1 sort of presentation, palsy. If it suddenly gets worse and they're known to have it, you could assume that maybe some of the tumor is in the bone and it's caused a pathological fracture. You can also get leg weakness, difficulty walking is very common, and then these questions you must ask if you're at all concerned about urinary retention and incontinence, and also fecal incontinence. So damage of your pelvic nerves or nerves leaving the outflow tract of the spinal cord can be responsible for this. So as briefly alluded to, with your true cord compression, it tends to be upper motor neuron weakness and sort of pattern. So you'd be less likely to get a hyporeflexia. Conus medullaris is mixed, whereas cauda equina, lower motor neuron pattern of weakness, hyporeflexia, and often unilateral. So I compared cauda equina and conus medullaris in a little bit more detail. So cauda equina tends to be a bit more of a gradual onset than conus medullaris. The cauda equina, we've already said unilateral because it's affecting the nerves that have come out at a particular, they've kind of left the spinal cord. You lose your reflexes with cauda equina, whereas it's reported that with conus medullaris, you actually keep your knee-jerk reflex. The radicular pain, so the specific nerve involvement, so a particular area of pain is more prominent with cauda equina, which makes sense. For conus medullaris, however, patients tend to report more back pain. And in terms of your digital rectal examination, you might find that the conus medullaris patients have numbness right around the anus, whereas cauda equina, it's the more general saddle region. I think what's really important to say here is that this is very much a academic slide. There's no sort of point if you were clerking this patient in A&E or wherever else in the hospital, if you were arguing about what the most likely differential is between these two at a junior doctor level. The importance is knowing to recognize all of these signs as worrying ones and what to do with them. So that leads us on to our final question of the day, which is, given the probable diagnosis, which is the most appropriate next step? So thank you all for your patience today. It's a final question. So if you head over to Menti one more time. So our options are high dose dexamethasone, high-dose prednisolone, immediate whole spine MRI, immediate transfer to a spinal center, immediate review from a clinical oncologist. So, a bit torn between the whole spine MRI and the high-dose dexamethasone. And once again, majority of the group take it. Well done. Yeah. So, it is most crucial, as long as there are no contraindications, that you give high-dose steroids, 8 to 16 milligrams per your trust guidelines, either orally or IV in the form of dexamethasone. Any swelling that you'll have around your metastases that could be impinging upon the nerves, you can reduce that swelling, potentially buying a little bit more time to allow you to do some of the other things in this list. Most trusts will recommend that within 24 hours, if you're suspecting metastatic spinal cord compression, which encompasses all of our true spinal cord, cauda equina, conus medullaris, that you get a whole spine MRI sequence in 24 hours. Involvement of a spinal surgeon may be required slightly later on. You might, on clinical suspicion, and once you've requested the MRI and given a DEX, you might want to get in touch with a surgeon, but they might say, look, we'll hold off until the MRI. But this is all, the most important thing is get the DEX in, get your seniors involved, and get that MRI booked. And likewise with the spinal center, getting the clinical oncologist may want to be involved, but not before steroids. So this is just a T2 MRI spine, just showing how it looks. I don't think there's any abnormalities in this one. So the white bit being our spinal cord there. So things to remember: MSCC is a medical emergency. Give dexamethasone immediately after diagnosis is suspected, unless there's a contraindication in place. High-dose steroids can be really nasty for the tummy, so give a PPI like lansoprazole alongside it, or omeprazole IV. If you're concerned about spinal instability, so if they're struggling to walk, if there's potentially a pathological fracture there, just get them to lie straight. You can use it's either pronounced ASIA or Asia guidelines to kind of keep an eye on their neurology and see if it's worsening. Crucial to get that MRI within 24 hours of presentation and refer for treatment from the specialists that are involved. One thing to say is that the rehab teams, the physios, the OTs can actually have a major impact on the sort of qualities of these patients by helping to improve bowel function, bladder function, by early intervention. So getting them involved is pretty critical. And then in terms of the definitive management, so for fit patients, you might want to consider them for decompression surgery. So you can do a laminectomy, removing the kind of back part of the vertebral bones and accessing to either relieve pressure or even remove some of the mass. You can take biopsies if this is the first presentation of the cancer, if you don't know where the primary has come from. And you can also consider giving radiotherapy, usually in the form of 5 administrations of kind of 20 grays divided across 5. If patients aren't able to tolerate surgery, if, for example, they've got multiple vertebrae that are affected, and therefore if you took a bit out of one, the others would kind of crumble or whatever, or if you needed to apply some metal work and you need the above and below bones to be working and they're not, then you wouldn't perhaps do surgery, or if they're just simply unable to cope with surgery, then that would be not an option. So in that case, you tend to just give a single blast of radiotherapy. So, and then once again, I said rehab team involved to help with bowel care. So that brings us to the end of our oncological emergencies, part 1. Please stay tuned for a part 2. We'll be covering the other 2 that were mentioned at the beginning of this session. It's a very useful topic for your exams, but also for clinical practice. It is, they are true emergencies, and having at least some knowledge in it can really make a difference. So yeah, thank you all very much.